Hello, everyone. Great to see you virtually today. So glad you could join us here, even at the top of the hour in the midst of our very busy days. Those of you who don't know me, my name is Jeein Yoon. I'm actually a general pediatrician. I worked at a federally qualified health center in Oakland for about a decade before coming to UCSF, where I practice now, also serving as the Senior Associate Director of CalMat. And just as we're getting started, if we could go on to the next slide. Let's go ahead and all introduce ourselves. I'm not sure if we can all do that in person, just given the number of us that are here. But go ahead and just drop into the chat your name, what organization you work for, the county where you see patients. And just as our grounding today, if you want to drop in one thing that's given you joy, hopefully today. Hopefully there was something today that gave you joy. And so let's go ahead and do that. And one thing that gave me joy today is just, I love the morning sun. Just seeing the morning sun, if I can get outside and just see the sky, this is something that gives me joy in general. So please do go ahead and drop into the chat your name, organization, county where you see patients, or where you work with kids, and one thing that has given you joy. So as you are all doing that, let's go ahead and move on to the next slide. Just a couple of quick words about our disclosures. Today we will be talking about diagnosing, treating anxiety in children. You see the names of the folks who are the planners as well as the speakers for this activity, and I'll be introducing our speaker in just a moment. But on the next slide, you'll see just a quick word about who's funding us, where our funding is coming from, and also the fact that none of the planners or the speakers have any financial conflicts of interest to disclose. And so please keep on dropping your interest into the chat. With that, I do want to introduce our speaker for today. We are very lucky to have with us Dr. Jeein Yoon, who is triple boarded in pediatrics, psychiatry, and child and adolescent psychiatry. Her primary interest is in integrating behavioral health and primary care pediatrics. Prior to joining the faculty at UCSF, she practiced as a general pediatrician for the underserved and high-risk populations at St. Christopher's Hospital in Philadelphia. She completed her medical school at Ewha Women's University College of Medicine in Seoul, South Korea, did her general pediatrics residency at Cleveland Clinic, combined child and adolescent psychiatry and adult psychiatry training at the University of Pennsylvania and Children's Hospital of Philadelphia. In addition to helping to answer the calls on the line, Dr. Yoon also serves as Associate Director for Resource Development here at CalMat. And with that, I am going to hand over, before I do, we are talking about anxiety today, and we no longer recruit people to share cases. So if you've got a patient that you'd like to share with all of us today, please send me a quick note in the chat. Let me know if you've got a case that you'd like to share. This is not like your sort of like medical school teaching case that's wrapped up with a pretty bow. This is a patient that might be making you scratch your head, maybe even stay up at night a little bit, wondering what's really going on here and maybe what should I do next? And we are crowdsourcing and learning from each other. What some good next steps might be. We're learning from our peers, and we're also learning from our subject matter expert here, Dr. Yoon. So please let me know if you've got a case to share. So quick word also that we are recording just the didactic portion of this talk. So, so just so you're aware. And with that, I will now hand the virtual mic over to Dr. Yoon.
Well, welcome. Nice to meet you all. I'm Jeein Yoon, one of the child and adolescent psychiatrists working on the CalMat team. I'm going to talk about anxiety disorders today, and I have 3 big learning objectives. I hope we can walk away with identifying and diagnosing anxiety disorders in youth, just learn how to explain cognitive behavioral therapy to families, just the concept of it, and learning about medication options for treating anxiety in youth. Okay, so what is anxiety? It's an overwhelming sense of apprehension, and it's usually a fear response to a perceived threat, such as you're running from a wild animal that's out to hunt you. It probably originated from like eras ago, that it was built to be a protective feature, just to serve to prepare us for any threats, keep us alive and safe. And it's normal to be there, and that's probably why we survived this far. The goal is not to get rid of all of anxiety, but to find a good balance of the perceived threat versus the self-doubt and perception that one's ability is not as good as you actually have to deal with a threatening situation. So when families come in with concerns for anxiety, there are three big questions that I ask myself in terms of, like, anxiety is normal to an extent, but when does it become clinically impairing? The first question is it developmentally appropriate for this child who is presenting to your office? Everyone has anxiety. I think the startle response in infancy, you're completely dependent on your caregiver to be fed, changed, put down for sleep. If there's anything that's going on, you cry to let them know, to take care of you. Then comes, like, from 9 to 12 months, you have the stranger anxiety. So you don't go to random strangers, get picked up and abducted. And from 18 months and on, you start exploring as you run, you walk, you start exploring away from your parent, but the anxiety is protective enough that you come back to your parent. So you don't go off 2 miles from where you started and get lost. As it evolves into, like, preschool years, lower grade school years, you start developing normal phobias, like fears around storms, needles, pain, natural disasters, which is transient. It will be there for a couple of years, wax and wane, but you will eventually grow out of it. And then comes the social incompetency fears, that you want to belong to a group of friends. We're all social animals. We want to be included. And if it gets to the point of impairing your functioning, you start avoiding situations, events, school, homework, and you see a gradual decline in academic functioning. It starts getting in the way of family functioning. You can't go out to, like, Disneyland because of that one child who fears, like, crowds, or certain phobias exist, and that kind of restricts you from engaging in, like, normal activities that the child should be doing at that developmental stage. The third question I would pose is, does this child have the ability to recover? Are they resilient? Like, a threatening situation may happen, but are they pretty resilient enough to bounce back? And if a similar opportunity arises, will they try to engage? Are they able to push through? Those are some major questions that you should be asking when they present. And I sometimes share this graph on the right with families that when we have treatment discussions about anxiety, I normalize the anxiety to an extent. Everyone has it. It's there to be protective. But when it's too much, it becomes paralyzing for us, that you have a fight or flight response. Sometimes you will avoid, like, doing homework. You will avoid test taking. You will avoid certain, like, stores or restaurants because you have a specific fear, and it becomes counteractive in terms of your functioning. If you have too little, that's not what we want either, because you're going to be too relaxed, too chill. You're going to lack the motivation to drive forward. So you want something in the middle that's just right, to have the most optimal performance and have fun in life. So we're going to look at the prevalence of anxiety disorders. I think this is important to review just to get a sense of what we need to screen for. So generalized anxiety disorders, I personally thought it would be a little bit more prevalent, but the lifetime prevalence is known to be around 2%. In general, and for teens and children, it's even less than that. It's under 1%. The earlier the generalized anxiety disorder onset is, you're more likely at risk to increase more comorbid mental health disorders such as depression, sometimes OCD, mood disorders. So that is something to think about in counseling, prognosis with families. Separation anxiety disorder tends to be a little bit more prevalent than GAD. In childhood, it's about 5%. In teens, it's less than that. Some risk factors for separation anxiety disorder would be a parental history of depression or anxiety and panic disorders. Specific phobia tends to be the most prevalent lifetime thing that will happen in kids. Kids will have it about 5% chance of having this. Teenagers more so, it's over 16%. It tends to have a prognosis of waxing and waning, and you do see this in like elementary school years. So that is something to keep note of. Panic disorders, usually it has a later age onset, usually in late teenage years. It tends to wax and wane and can be chronic, about a 2 to 3% prevalence. And social anxiety disorder is actually one that I want to make note of. It is a lifetime prevalence of a 7% chance, and it tends to persist if left untreated. The median age of onset for this is usually in like middle school, high school years. So that's something to make note of when you are screening for anxiety disorders. So that brings up the question of what do I do for anxiety screening? The US Preventative Task Force came out with a new guideline recommending screening for anxiety in all children ages 8 and up annually, as if you would do PHQ-9 screening for depression. Now, I think all of us are pretty familiar with the GAD-7, which is widely used in primary care and adult settings as well. This screener is validated for ages 11 and up. And I put 17 here because we're dealing with the pediatric population, but it is validated for adults as well, and it's widely used. We need to be careful about this because GAD-7 only looks at generalized anxiety disorders. The 7 question that it poses is based off of the DSM-5 criteria for generalized anxiety disorders. And I think sometimes we forget about that. If you just look at the GAD-7, you're not asking about all of the other questions about social anxiety, separation anxiety, panic disorder symptoms, or social anxiety. I personally prefer the SCARED screener, which is the screen for child and anxiety related emotional disorders. It is a lot longer in question length, about 41 questions for each form, which they have a parent version and a child self-report version. It's validated for ages 8 and up, and it's a lot more child friendly in the language and the way they ask the questions. The kids might have a little bit of difficulty with focusing, so they can break it up. I usually give it out so they can do it at home and bring it back, or do it in the waiting area. It's probably going to be challenging to finish in a 15-minute follow-up visit. But this one does address panic and somatic symptoms, separation anxiety, social anxiety, GAD, but also school avoidance. So this is more the preferred screener that I do recommend. For kids under the age of 8 that can't use the SCARED screener, you have other options such as Spence Children's Anxiety Scale, the Preschool Anxiety Scale. And if you have specific concerns and want to do a deep dive into social anxiety, there's a Lebowitz social anxiety scale that is all freely available on the web. So now we're going to move on to cognitive behavioral therapy. So cognitive behavioral therapy, in short, we often call this CBT, is the first line evidence-based treatment for anxiety disorders. It's very specific in terms of goals. It is a time-limited treatment strategy. You don't do this for years and years. It's usually really focused on doing 12 to 20 sessions. It can happen in an individual setting with parent involvement versus a group setting with a couple of kids who have anxiety, and there's a concurrent parent group that runs. I want to emphasize for psychoeducation purposes, when you are kind of introducing the concept to families, that parent involvement is crucial. So there is going to be a parent component. They need to participate and make sure that they understand what the therapy is. There's weekly homework happening, so the child should do it, but also the parent should participate in that. And when parents tell me they're doing therapy and I ask and they say they don't know because they just drop them off with a therapist and go go grocery shopping and come back to pick the kid up, I kind of question, are they really doing CBT? So you want to ask about that too. Really, I'll go into the details of each step of cognitive behavioral therapy, but the motto is you got to shrink the risk and then approach and expose for the behaviors we are targeting. So generally speaking, with CBT, the hypothesis is when a certain event happens, it's not the event itself that causes the individual to have certain feelings of anxiety and certain like behaviors. It's usually coming from an automatic thought that is coming at lightning speed. You might not even be aware that you're having these brief thoughts that are unchecked. They may or may not be true, but you truly believe and incorporate it to be a core belief system. And that triggers like anxious feelings. I really don't like this feeling. It's making me uncomfortable. You might have panic symptoms of like hyperventilation, sweating, you feel dizzy. I feel like I'm going to throw up. And then the response comes with behaviors of a fight or flight mode. You're going to avoid the task, procrastinate, or just try to run away, shut down. Get really irritable and have temper tantrums. So this is the model that they think of, and we need to break the cycle by kind of making some tweaks. So we'll give an example of cycle of anxiety. So a situation or an event happens, midterms are coming up, and we have 3 different students might have very different automatic thoughts come up. The thoughts are really brief. Some kids will not be able to pick up that they're even having these thoughts. Student A thinks I'm going to fail. Student B might think, okay, maybe I won't fail, but I'm just not feeling prepared. What if I get a B or a C? That's not good enough. And student C will feel, I'm ready for this exam, let's go. So depending on the thought you have, that will lead to a physical sensation, such as like palpitation, sweating, or some kind of an emotion that's uncomfortable for them. And it will lead to a behavior. Student A might just procrastinate. I'm going to play games. I don't want to think about this, or avoid the situation. If the avoidance is not bad enough by 10 o'clock, they might try to pick up and read a couple chapters and get their work done. Or some will just completely shut down and avoid to the end. Student B who feels underprepared might overstudy. What might possibly or like reasonably be done in 4 hours, they might put in 20 hours or 30 hours and over prepare. And for the consequences of that, they feel short-term relief. Student A is going to feel good, like not feeling the uncomfortable feelings of anxiety while they avoid the situation. But in the end, it's going to be a negative cycle of repeat and rinse, repeat and rinse. So that's not going to help the situation. Sometimes it just consolidates the problem and anxiety, snowball effect, and your core belief system gets stronger and stronger with these automatic thoughts. So what we want to do in cognitive behavioral therapy with the cognitive part of restructuring is we try to externalize the worry thoughts a little bit. Have the kid call it or give it a silly name. It can be the worry brain or the protector brain. Sometimes I have kids call it the spam mail. So they need to be able to check and stop themselves. Okay, what thought just happened before I had these feelings or I'm doing these behaviors? So we're going to backtrack and use their worry brain to shout out what was the thought process going on. And we'll work on educating the patient and the family that feelings don't equal facts. They aren't always necessarily true. The thoughts aren't facts either. So we're gonna have the detective mind or the fact checker check the facts, and they're gonna need a little bit of assistance in breaking the cycle, just kind of doing some validity testing with a therapist or a third person. And sometimes that's going to be mom or dad or whoever they live with at home as they practice this throughout the week. It's like a headache diary. We give them a diary to write it down, what happened. Let's backtrack. What were the thoughts? Okay, let's come back and check the facts. We'll do it with a therapist first. And then as we get a little bit more familiar with the process, you're going to do that at home with your parent or caregiver. So the cycle is going to be recognize the automatic thoughts. Let's make check the facts and make more of a realistic interpretation, challenge the facts of that or what you're thinking, and remold the self-talk. And gradually you're going to be able to move the cognitive piece of that and remold the core belief system. So the end result for this is we really want to shrink the perceived threat and increase the ability to cope, or at least you have a better confidence level with your perceived ability to cope. Now, some kids are going to need to learn some coping strategies along the way because the somatic symptoms, the physiological response is so big, or they're just really having like poor distress tolerance with these feelings that come with the thoughts. So some of the easier techniques that you might already be teaching in primary care, that's pretty simple and the therapists do the same, is teaching them how to do breathing exercises. Box breathing is one. You just slowly walk through the steps of you inhale slowly over 4 seconds, hold the breath for 4 seconds, exhale slowly over 4 seconds, and hold the breath over 4 seconds. I know some people call this 4-1-5. You can kind of tweak how long you want to hold the breath, but you repeat the cycle about 5 to 10 sets, or at least until they can calm down a little bit. And then just kind of calm down the physiological response. For little kids who aren't able to do that, you can blow bubbles or watch a YouTube video on Sesame Street that has like good belly breathing exercises. YouTube has a bunch of progressive muscle relaxation techniques, and ice diving. And we always recommend if they can get like some structured exercise or physical activity in, that's always helpful too. Now, once we get over the cognitive portion and the coping strategies, we will work on the behavioral strategies, also known as exposure therapy. Now, in essence, it is based on opposite action techniques. Do the opposite of what your worry tells you to do. If it tells you to avoid the situation, we're going to face the situation. And to do that, we got to be careful, because if I have a fear of heights, I'm not going to tell you to jump off a 100-foot bridge from the get-go. So we're going to have to build a exposure hierarchy, and we'll look over a sample of that next. And depending on the exposures, what we can do in real life versus not, we can do it in vivo or imaginal. So this is a sample that I borrowed from one of our CBT therapists in UCSF San Francisco. So a kid comes in with separation anxiety. We'll take an inventory of what they aren't able to do in their daily, weekly life at that developmental level. The mom is saying that I can't cook in the kitchen while the kid is playing in the living room. They want me to be there all the time. I can't even go out in the yard to do any gardening because they want me to be in the living room all the time. I can't even drop them off for a play date at their friend's house. I have to sit there for the full 3 hours because they want me to be there all the time. So we'll take an inventory of all of the activities they're not able to do independently without mom, and then ask the child, okay, there's a fear elevator. We're going from ground 1, ground level, all the way up to 10. The higher you go up, it's going to be scarier. Can you tell me what level you're on when I ask you to play while mom's cooking in the kitchen? And they will report, that's a level 5 level of fear for me. What if mom goes outside and gardens while you play in the living room? That's a level 7 or 8. And then they might, when you ask about the play dates and being dropped off by themselves at their friend's house, they might rank that as a level 8 or 9. So we'll work on the lowest level activity to expose that first, and you'll work with a therapist to set the time of exposure and see if they can master that over the week. Come back, check in. How did that go? Do any problem solving? If we failed, we'll kind of tweak the activity of exposure, repeat. Once they master that, we will move up a notch to the next level of activity and devise the plan. And we'll gradually move up the hierarchy. So next I'm going to move on to medication management. So when do you consider treating with medication and anxiety disorders? I want to emphasize that for anxiety treatment in children, all the time it's going to be first line, recommend CBT therapy. However, it's not as easy to access sometimes. Quality standard of treatment, there just might be logistical reasons that the family can't engage. There's a long wait list, insurance parity issues. So I'm mindful of just taking the full clinical picture and barriers in real life. But if there is, assuming that they are in therapy, we try therapy first, and there's limited improvement after 3 to 6 months. The anxiety is actually interfering with the ability to engage in therapy with the therapist. They can't engage in the exposures even when they try doing the lowest level of therapy. They can't utilize their coping strategies. And you get that collateral from family and the therapist. That's something to consider. If the presentation is so acute, it's really impairing this child's daily life. They just can't leave the house. They can't eat. They can't go and play outside with their friends. You might want to consider doing combination treatment if that's available. Um, if the more acute and severe the anxiety is, combined treatment is likely going to be most effective. I just wanted to drop this slide in so we don't miss the bigger comprehensive picture of things. Now, at the bottom of the pyramid, if you have anxiety symptoms, but you're somehow chugging along, going to school, you have friends, you might feel uncomfortable, but we're doing things. We're going to start with therapy, and if indicated, add medication treatment on that. Now, if it's been kind of stringing along for years and years, and it's slowly creeping into just poor adaptation, you just don't have the coping skills, and it's spilling over into your life at school, work, wherever that may be, and it's showing, you have to think about, do we need to support this child with a 504 or IEP plan if school is being really affected? Do we need a school-based counselor to be involved if the anxiety is surrounding things going on at school? Do we need to support their learning environment if that is one of the bigger causes of anxiety? So we want to think about that and not miss that, let it go. Now, some kids will either work up the ladder of tier 1, tier 2, and get to tier 3, or some just jump straight to tier 3. If there is, you want to screen for any safety concerns or high-risk behaviors. Some kids will start engaging in self-harm of cutting. You'll ask them, I just can't stand the overwhelming feeling. I just want it to go away. And my distraction technique is I release the pain, the anxiety that I'm feeling by cutting. Or I immediately jump to thoughts about, I just want the world to end. I'm done with life because I don't want to feel this way. They're not necessarily always having SI or cutting behaviors because they're depressed. A lot of times it's comorbid, so you do have to screen for depression as well and other mood disorders, but sometimes anxious kids will take the drastic measures to get out of the situation, and it's a flight or fight response. So we have to ask about those. And similarly with substance use and drinking, that is somewhat of a maladaptive coping mechanism that makes them feel better. And sometimes we call it self-medicating, although I don't love that term. So if that's the case where you have high risk behaviors or some self-harm going on, you might have to focus on stabilizing that, do safety planning, and work on the behavioral treatment strategies for that first before you go to the traditional cognitive restructuring piece. Now, I want to go over some evidence-based treatment guidelines and studies that are pretty big. This is a landmark study in child and adolescent psychiatry that was published in 2014. It's called the CAMS study, Child and Adolescent Anxiety Multimodal Study. It was an NIMH-funded double-blinded RCT, and it had enrolled about 488 youth between the ages of 7 and 17. I think the average mean age was around 12, give and take a year or two. And these children were all diagnosed with either generalized anxiety disorder, separation anxiety disorder, or social phobia. The majority of kids had at least 2 or more diagnoses, I think. And we randomized them into 4 groups. One group had the combination treatment of both therapy and medication. The second group had medication, and in this study they used sertraline. The third group had cognitive behavioral therapy only, and that was 14 sessions. And the last group was a placebo group. So if we look at the results of the study, it was divided into a phase 1 trial and a phase 2 trial. The phase 1 was the first 12 weeks of acute treatment on the left. And as you can see, the y-axis looks at the CGIS scores. The lower the scores are, it means you're close to remission. So under like 1 to 2 would be a remission, almost minimal symptoms. And the purple graph, that's kind of really taking a steep dive in the first 12 weeks, is the combination group that received both CBT and sertraline. And that at week 12, it was superior with clinical significance in reducing symptoms over a monotherapy group, whether that was CBT only or SSRI only. However, it was interesting to note that in phase 2, the shaded area, they checked at week 24 and week 36, and they just did maintenance therapy for all of these groups. The medication only group, which is the red curve, and the CBT only group, which is the green curve, kind of caught up rapidly with the purple graph, which is the combination group. So by week 36, there wasn't a huge clinical significance in terms of differences, and they all kind of converged to reducing symptoms. So in essence, like by week 36, which is about 9 months from the start of the study, if you received any type of treatment, whether that be CBT only, SSRI only, or combination treatment, the outcomes were pretty similar and effective. But in the first 12 weeks, if we look at the short term of acute period, the combination did the best. Any therapy was better over than placebo therapy. So a couple of things to think about. You want to talk with the family to see like how acute is the presentation, how impaired are they? Do we have time, and are we okay with waiting the 3 to 9 months for some response to come? Or is it worth trying a combination approach to kind of expedite things and relieve some of the distress going on? So I just wanted to point out, if there's nothing available, SSRI monotherapy might not be a horrible choice. I'm not vouching for this, but I'm just saying with the access issues, sometimes this is to be considered. Now, in 2018, they did a follow-up study from the CAM study, and they named it the CAMEL study. So they re-recruited about 319 participants from the initial study. And depending on the individual entry point of the initial study, these kids were 4 to 12 years out from the initial trial. They wanted to look at how many of these kids were in remission status over a 4-year period. They checked in once a year and just had questions about that. We'll look at the figure on the right first, figure 3. The red bars look at the responders from the initial study. The green bars look at the non-responders from the initial study, and the blue bar is like a combination of both, the total. And they counted the remitted group, the relapsers, and the chronically ill group. And there's something to highlight that regardless of whether you responded to the initial study or not, 48%, almost half of the participants had relapsed. And we went back to look at which treatment modality has the best chance of falling into remission. Unfortunately, like you can see, CBT, sertraline, or like combination therapy, they all came out pretty similar. There was no distinction. So the treatment modality, like no matter which group you were in, didn't really predict whether you're going to be in remission or not. Rather, what they found out was the positive predictors for remission was whether you had an early response to treatment. which like kind of will tell you you're going to have a better chance of not being in the chronically ill group. Also, some other positive predictors were being of male, gender, not having the social anxiety diagnosis, better family functioning, and fewer negative life events. I just wanted to kind of compare a different study that looks at similar things. So for this study as well, they looked at combination treatment versus SSRI only, and they kind of stratified it to Caucasian versus non-Caucasian population. Combination treatment had robust outcomes for both anxiety and depression, and this one looked at both kids who had anxiety and depression together and anxiety alone, depression alone. But I'm just highlighting this that it was really effective if you did combination therapy. The benefit of CBT didn't start separating and being meaningful until like week 12. So, I mean, I think it's common sense. There's like a learning curve with therapy. So the first 12 weeks, it's not going to be evident, but that's when CBT starts shining. The solid lines here are the white population. So the red solid line looks at the combination treatment for Caucasians. The blue solid line looks at SSRI only for Caucasians. And the dotted lines look at the non-Caucasian population. And you'll see that the response is lesser than the Caucasian population for some reason. And even for combination treatment, which is the red dotted line versus the red solid line for Caucasians versus non-Caucasians, there's a little bit of a difference there. So minority youth did relatively poor, even in combination treatment compared to the Caucasian populations. And I don't depict the other graphs here, but if you are a boy, if you're older at age of presentation, engaging for these treatments, if you have other comorbid externalizing disorders, you do have a poorer response. And in this article, they discuss why would that be. One of the theories was that a lot of the CBT or psychosocial treatment modalities are based on a non-diverse population. A lot of the therapists might not be culturally attuned or sensitive in incorporating and adapting these therapy modalities. Sometimes minorities have like limited access to standardized like quality treatment. So there's a lot to consider when we are looking at outcomes. Now, I often get the question of, can we do an SNRI? This may be coming from the families, sometimes from the PCP. They have their own reasons from like personal family experience, history. So we'll look at the studies that look at this. If you use an SSRI, like you'll start seeing a very small, the effect size is really small, but it will start working at week 2. I think by week 12, you'll have a significant clinical improvement in treating anxiety. But as you can see, the steepness of evolving meaningful change here, SSRIs have the greater magnitude of early response compared to the SNRI. So this is something I would talk about, like, unless there's like a really strong feeling. I mean, I don't discount the nocebo effect, so I do take that into consideration. But this is what is out there with studies that the SSRI seems to do a little bit better over SNRIs. So our first line choice would be an SSRI. And this is just a table to give you an overview of what is FDA approved. It doesn't mean that you can't cross-reference and use the ones on the left column for generalized anxiety or depression and vice versa. It's just what's out there based on industry studies for many reasons for funding, I think legislations and lobbying. So, but we know for safety purposes that Zoloft or sertraline is approved as young as age 6 and up. Prozac can be used as young as age 7 and up, and Lexapro or escitalopram is age 7 and up as well for GAD. The indications for MDD and depression are a little bit higher, but we can safely use it, and we can answer any questions about medications later on. So what if you don't see a treatment response? I think I have to evaluate, are they ready for change? Does this family or patient have too much going on psychosocially? They don't have the bandwidth to engage, or they're just not ready or fearful of engaging because they can't really engage in coping skills. Um, we have to take a good history about the medication adherence. Are we monitoring them correctly? Are they only using them half the week? Did we ever get them up to an effective dose, or did we stop at a suboptimal dose, like subtherapeutic dose for them? And did we give up on treatment too soon and called it a failed trial? Did we put the appropriate supports in for any safety concerns, maladaptive coping mechanisms like school supports? And then if all of the above has been checked and we're still struggling, we have to think about, was the diagnosis correct? We'll have to come back to the drawing board for that. So what can you do in primary care offices? As a pediatrician, I think psychoeducation is really important. Even in specialty care offices, I will spend an enormous amount of time on just describing like what our diagnosis is, what's the prognosis, what could happen if we didn't support this? Are we enabling these behaviors and just growing the anxiety more unintentionally when we were really trying to help the child and support the parents to be calm and confident and just kind of correct the course a little bit if they're engaging in counterproductive measures. Consistent routines and schedules are very important for anxious kids. We want to reduce the stressors, any acute risk stressors that we have control over. We want to correct that. We want to externalize the fear and anxiety, give it a silly name. We want to do the fact checking, discourage any avoidance of appropriate situations. I generally don't write school excuses for long periods of time if it's anxiety based, unless it's an acute trauma situation that is really threatening their safety. Um, I don't excuse them for school for weeks and weeks. Rather, if it is, it's going to be a temporary, like modified schedule while we're working with the school to reintegrate the child back to school. And we want to build a hierarchy and gradually expose back to fears. And if necessarily, we're going to build a reward system for behaviors. So in summary, I think identifying anxiety is half the battle. Like psychoeducation and setting expectations will be key. And that's like a huge role that you could take on. The families trust you. They have a long-standing relationship with you. And CBT is the treatment of choice. That's the first thing we want to go to. And SSRIs, if applicable or indicated, we can go there. That would be the choice of medication we go for. And don't forget about the 3 tiers of treatment. I
Fantastic.
left
Thank you
a
so
couple
much. Oh,
resources
go ahead.
in the end. I'm not going to go over that, but while we're waiting for therapy, I think the Don Huebner manual for what to do when you worry too much. It's like great for lower grade school kids. It's kind of a workbook with pictures. They can draw. They can work on it with their parents. And then I left some resource books for parents as well.
Fantastic. Thank you so much for this great talk. And we'll be putting a PDF of these resources onto the IECHO site, so you can take a look at these later. 1 or 2 questions did come up. One question did come up on the different, like especially for the CAMELS study, the difference. How do you know the difference between relapse and withdrawal from meds? And so, if you could speak to what relapse looks like, what SSRI sort of like withdrawal might look like.
So that's a good question, and I don't think they went into details of when they withdrew the medication, time point of withdrawing. And
Yeah.
generally, I think the guideline is we don't have a very hard guideline in terms of when is the appropriate time to come off of SSRIs if you have been started on one. But we do recommend 12 months of smooth sailing in remission is when we consider tapering off of medications. Withdrawal, like SSRI withdrawal symptoms by definition would be more the physical side effects of like flu-like symptoms. You might have chills, fevers, muscle aches, and then rebound of anxiety symptoms. So that's more short term. That usually rides out. But I think whoever's asking the question is asking about how do you define relapse if you're off a medication. So we wouldn't take them off medications unless we were sure they were in remission for a good amount of time, and we're talking about months, and then taper them off. And then once that happens, you might be a relapser if your symptoms come back to a clinically diagnosed level.
Question also came up about, just to follow up on that, how you might taper an SSRI when you're deciding to discontinue.
So it's a discussion to have, like, for different scenarios. If we're having side effects, I think we have to like weigh the pros and cons of staying on, and if it's not tolerable, we're going to taper it off. How fast we do it depends on the half-life of the medication you choose. So sertraline, Zoloft, or Lexapro, citalopram have fairly short half-lives. So even if you miss a dose or two, you might feel it a little bit more stronger, especially if you are sensitive to the side effects. So I generally recommend gradually tapering off if you have the time and it's not an acute situation with bad side effects. So if we went from 5 milligrams to 10 milligrams, that was how we titrated up. I would back them down to 5 milligrams for a week or two before tapering them off completely. If you are dealing with a longer half-life drug, which the only one we would use in this situation would be fluoxetine or Prozac, that generally it auto tapers, to be honest. So you can go cold turkey and it will just gradually taper off in 2 weeks or so. So that one has a little bit less of physical side effects from withdrawal that you would experience. We never do Paxil, paroxetine. That one is really, really hard to taper off for kids or adults. You're going to get really bad physical withdrawal symptoms. So sometimes we have to bridge with a longer acting fluoxetine to kind of curb that response. But I don't think that we don't generally prescribe that.
And this question I want to kind of open up not only to you, but also to others here who know good online programs for cognitive behavioral therapy, because it can be often hard to find trained therapists, especially in some of the more remote areas. So Dr. Yoon, if you've got any recommendations, also Dr. Schumacher, if you've got any recommendations, plus anybody else here that you know of, if you know of good online programs, this is a great time to share the places that you know about.
You mentioned one. So Clarity Pediatrics, which has come up before for some of their ADHD treatment, is now offering Space, which is a parent-based group for helping parents, giving kind of parents skills to help manage kids with anxiety, as well as a teen anxiety group that are both online, and they accept a number of insurances. So that can be a good option in areas where there's less therapy resources.
That's great, especially since they often take Medi-Cal, and so that is a great resource. Others that people know about? I do want to talk about, there's this program called Project Empower, and I'll drop, I will look for that and then drop into the chat later. But it's basically free 1-hour training for parents, basically on how you do exposure therapy for your kids. And it's really geared towards parents of school-age kids. So that is another resource. And any other resources that people know about that offer either online CBT or online parent training?
I think Coping Cat for parents, I think someone mentioned it, but that would be good.
The Coping Cat being another online CBT-based program, which is great. And Tina, thank you for your GoZen. It sounds like Jeein has a lot of great mindfulness and other stress management techniques for kids, which is fantastic. Another question did come up here about, so there was that one study that showed decreased response to both CBT and SSRIs and that combo treatment among minoritized children. And was there any examination of, say, racial or cultural concordance with the therapist as being a factor?
So no, not exactly. I think the majority of therapists were not concordant with the minority population was the point and discussion point. That was the limitation of the study, to have a concordant therapist to patient match, but that is what is being discussed as the limitations of the study and what needs to be looked into.
Great. Let's go ahead and stop. Let's go ahead and move forward just a little bit for those